Thank you, Supratik, for that kind introduction. So today I'm going to try and talk to you about non-diabetic kidney disease. Some of you might have read about 3 days ago there's an article published by the European Renal Association ahead of print, which suggests that we should be replacing the terminology of diabetic kidney disease to kidney disease with diabetes as a risk. And that's because what we thought was a homogeneous disease, that any individual having diabetes and kidney disease is likely to have diabetic kidney disease, that is a bit out of the window. Even pure diabetic kidney disease, as we know in terms of biopsy, has variable degrees of glomerulopathy, tubulopathy, and mixture, and differences in interstitial disease and vasculopathies. But I'm not going there what is going to be in future, but talking about what we are supposed to be talking about in the current. So to clear a few terminologies, textbook definition of diabetic nephropathy says that there has to be persistent albuminuria on at least 2 occasions, and such patients usually invariably have hypertension. Glomerulopathy is a term reserved when you've actually done a biopsy and proven that you have glomerulopathy in a patient with diabetes. And diabetes kidney disease, or DKD as we call it, is when we are talking about a presumptive diagnosis of kidney disease in subjects with diabetes, and you assume that it is because of diabetes per se. Even though we use all of these terminologies interchangeably, the terminology that we all talk about in general is diabetic kidney disease. But what is the reality of kidney disease in an individual with diabetes? So it could be because of diabetes per se, true kidney disease because of diabetes. It could be due to any other cause on earth other than diabetes. The individual incidentally has diabetes, so what we would call non-diabetic kidney disease. And in some of the individuals, you might have a bit of both. So the individual has diabetes, he's got kidney disease related to diabetes, and maybe some other kidney disease as well. The other degree of heterogeneity that we have in terms of kidney disease is albuminuric versus non-albuminuric kidney disease in diabetes. And it's not necessarily that it is because of diabetes itself or because of non-diabetic kidney disease. So like my previous speaker, I have probably not been that clear, but I've been able to muddle you up to say that there are different kinds of kidney problems in individuals with diabetes, just like neuropathy is heterogeneous. Now this is Mogenson's staging of kidney disease, stage 1, stage 2, stage 3, stage 4, and stage 5. This is what we were taught in med school, right? But remember, this staging is classically for type 1 diabetes. This is not meant for type 2 diabetes. And if you go back, this is from, you will still find this particular figure in this current Harrison's textbook as well, which is from UKPDS 64. It suggests that there are stages through which an individual goes through. That is, individual will initially maybe have a stage of hyperfiltration, then develop microalbuminuria, then a proportion of them will go to macroalbuminuria, and then there will be a decline of EGFR. This again is something which is conceptually no longer accepted. So you will have individuals who will have no albuminuria and straight away have a decline in kidney disease, EGFR, and you will have individuals who have albuminuria, macroalbuminuria, who will never have decline in EGFR. So the issue is, it's not that easy, because if you have a patient in front of you, you do an ACR and you calculate an EGFR and you tell the patient you're doing fine, we'll see you again in a year's time. 6 months down the line, that patient might have some kind of kidney disease. So this entire concept that we are trying to predict in an individual, that you will first have albuminuria, or even if you don't have albuminuria, initially there will be a slight decline in EGFR, and that will tell you that you are going to progress to kidney disease, is a concept which is very rapidly disappearing. The other issue is uncoupling of renal impairment from albuminuria. So this was quite an interesting article when non-proteinuric kidney disease happens. So you will have a significant proportion of your patients with kidney disease in diabetes who never ever develop proteinuria at all. So coming to pathological classification, this is one of the seminal papers on the basis of which currently we use criteria for defining people with kidney disease in diabetes. It is pretty standardized and all clinical trials are supposed to report this, and it looks at certain components when they are looking at the histopathology under immunofluorescence or electron microscopy. One would be to look at what's the state of the glomerulus, and that's the grading. We do not necessarily need to know. Looking at interstitial lesions, is there interstitial fibrosis, is there vascular lesions? And on the basis of that, we are supposed to classify true diabetic kidney disease as 1, 2A, 2B, 3 and 4. So next time you see a histopathology report, insist upon the use of immunofluorescence and electron microscopy and the grading to say, please tell me what is the grade of glomerulopathy and what is the involvement in terms of tubulopathy. Now, coming to non-diabetic kidney disease, I still remember one of the first classes that I attended as an MBBS student. My teacher told me, if you have 100 patients with diabetes and kidney disease, you can be assured that at least 95% of them is because of kidney disease due to diabetes per se. In only a small proportion, you will find that they have kidney disease because of other causes. And this is what we have been traditionally taught. I am sure this is what the audience follows as well, that if you don't have retinopathy, if there is a rapidly decrease in EGFR, if there is rapidly increasing proteinuria, if there is refractory hypertension, in the urine you have active sediments, or you have signs and symptoms of other systemic disease like rheumatoid arthritis, SLE, vasculitis, and if there is a very great reduction of EGFR following the institution of an ACE inhibitor in ARB, think of causes of kidney disease other than diabetes, that is non-diabetic kidney disease. And this is again from Harrison to tell us that these are the same criteria which we were told, please send this patient to your nephrology colleague, he will want to do a renal biopsy to figure out whether there is non-diabetic kidney disease. The unfortunate bit is, if you look at clinical trials and clinical studies looking at non-diabetic kidney disease, these studies all almost universally report retrospective data. So some center has done 500 biopsies in the last 10 years, and they come up and say this is the proportion of DKD versus NDKD. The challenge is the nephrologists did those biopsies in individuals that they thought had non-diabetic kidney disease. So therefore, there is a selection bias in terms of what they have chosen to perform the biopsies in. But if you now go by certain of the Indian as the European studies, they have variably stated that the proportion of that non-diabetic kidney disease, which my teacher told me was only about 5%, is somewhere between 20 to 30%. And what are these causes of kidney disease which account for non-diabetic kidney disease? It's the same diseases that you would see in an individual without diabetes, the same causes, right? And this is one study published almost 18 years ago. This again is an unselected biopsy study which suggests that the proportion is 1/3, 1/3 and 1/3. And interestingly, this association of retinopathy with kidney disease is stronger in type 1 diabetes, but not so in type 2 diabetes. So 90% of type 1s with DKD will have retinopathy. Whereas if you are looking at type 2 diabetes, you will have a significant group of people who will have pure diabetic kidney disease but will not have retinopathy. So the fact that somebody does not have retinopathy does not mean that this individual does not have kidney disease because of diabetes. And 70% of DKD patients, so if you choose biopsies on the basis of this guy does not have retinopathy, let me go and do a biopsy, 70% will come back with a true diabetic kidney disease. So all of those discriminators that we have been taught are questionable. So with that, we started a project, a multi-omics project, about 5.5 years ago, and I'm going to present data from that. So until about 2021, we had screened about 6,247 patients, and the type 2 diabetes patients screened were about 5,388. We performed EGFR, ACR and an ultrasound, and we decided that we will take individuals who are in stage 3 CKD. Because if I'm going to do or offer unselected renal biopsies, on one side if I do it in burnt out disease, I will not get any meaningful information. So CKD stage 5 doing a biopsy makes no sense, whereas my ethics committee will never ever give me permission to do a biopsy in CKD stage 2 or stage 1. So they either were in CKD stage 3 or they had significant albuminuria. And we offered them a renal biopsy prospectively in an unselected manner. And what we found was, if you're looking at the proportion, that about 2/3 of our patients that underwent biopsies had pure diabetic kidney disease, and about 18% had non-diabetic kidney disease. That's a very big number, because if you're looking at India, you are saying 10 crore have diabetes, 3 crore will have kidney disease, and if 1/3 has a non-diabetic kidney disease component, it means 1 crore in India has kidney disease in diabetes, wherein there is a non-diabetic kidney disease component. We tried to look at all of the factors, I'm not going to bore you there, of the baseline parameters to see, can any of these parameters tell us that A or B can help differentiate between DKD and NDKD, because that's what we've been taught. And we've looked at the clinical parameters as well, the history and examination. So finally, if you look at the two things that stand out is duration of diabetes and the presence of retinopathy. Now in type 2 diabetes, how reliable is your duration of diabetes? So that does not help you in the patient in front of you. That too, if you look at, the odds ratio is 1.02. So statistical significance does not necessarily mean clinical relevance. And with regards to retinopathy, even though there was a 18 times greater risk of having retinopathy if you have DKD, look at the confidence interval from 1.2 to 277. So statistically, again, it is important, but for the patient in front of you, sitting in front of you, it does not help you to differentiate between A versus B. So this bit of the study, NDKD is very common. So let this audience go back and realize that there is a significant proportion of non-diabetic kidney disease component in our patients. And the use of traditional indicators for renal biopsies indicated that almost 90% of our patients should have had a biopsy, because there was some box that each of these patients were ticking. And if you did do a biopsy in those 90% of those patients, 2/3 of those patients will actually have DKD. So is it a good discriminator from a clinician's point of view? No. And the results indicate that the clinical laboratory parameters are suboptimal in helping us pre-select individuals who would benefit from renal biopsy. And in our cohort, about 14% had non-albuminuric kidney disease. If you remember UKPDS, close to 45% of patients had non-albuminuric kidney disease. So maybe what we were looking at that point of time versus now has changed to a great extent, and we are having even lesser number of non-albuminuric kidney disease because we are now using ACE inhibitors, we are all using SGLT2 inhibitors. So the disease has changed from what it was 30 years ago in terms of degrees of albuminuria. So we've published this bit of the data that I've discussed in the British Medical Journal. So you might argue and say, how does it matter that diagnosing non-diabetic kidney disease is important? Because is it different in terms of prognosis? Is it different in terms of outcomes? Otherwise, there is no point in identifying the problem in the first place. So we have followed up that cohort longitudinally over a 3-year period minimum to look at composite renal outcomes, because that is what matters in today's world. To say that this patient, DKD, does it do worse than NDKD? Because if I identify NDKD and if I give specific treatment like an immunosuppressive, does that patient do better? Otherwise, identifying NDKD does not make any sense. So currently, there is paucity of studies. Again, in terms of composite renal outcome, it's all retrospective data and small number of subjects with conflicting results. And again, remember, even the data that was published from all of these guys, those were biased selected biopsies. So the clinician thought that these are the worst patients, therefore I do the biopsy, and therefore their outcome might not reflect what happens in the real world in terms of our normal patients. So we tried to look at the composite renal outcome, and secondly, we tried to figure out, is there anything at baseline which would predict to us which of our patients are going to do well and which of our patients are going to do badly. So I'm going to skip some of the slides because of paucity of time. So we documented all of the clinical and biochemical parameters like I showed you in the previous study itself, and we had the histopathology in all of our patients. And we followed up all of these patients every 3 months with an EGFR, 24-hour urinary protein. Every parameter for composite outcome was evaluated. And what are the composite renal outcomes? We all know about it, right? Doubling of serum creatinine, 57% reduction of EGFR, ESRD, need for a renal replacement therapy in terms of either dialysis or renal transplant, and renal death, the standard renal outcome protocol. And we only included those people in whom we had complete data for minimum 3 years in the study. And we looked at differences in renal outcome studied at the end of follow-up period. The change in EGFR was also calculated. So you had about 120 people that we started off with, of which about 80 had DKD, 21 had NDKD, and we removed the mixed kidney disease group because that would muddle up the results in terms of the outcome. And we looked at the composite renal outcomes. As you can see, there's 33 patients attend an endpoint event versus 3 patients in the 2 groups. And this is the difference between the 2 groups in terms of their clinical baseline parameters, hardly anything to choose between them, relatively matched in terms of their age, gender, and other parameters. And if you look at, you might wonder and argue and say there might have been a very big difference in the drug therapy which actually led to a difference. As you can see, use of Finerenone was very low because I work in a government hospital, and Finerenone came very late in the study. By the time we had already been, the study had been ongoing for a long period of time. And if you look at the survival difference, I think it's a no-brainer to know that those with non-diabetic kidney disease were doing far better than patients with pure diabetic kidney disease. So the fact that we were able to identify these individuals with non-diabetic kidney disease, and the fact that we gave specific treatment for non-diabetic kidney disease in these individuals, it changed the clinical outcome dramatically. And most of this was driven by the doubling of the serum creatinine rather than ESRD and renal deaths. And as you can see, the slopes of the EGFR between DKD and NDKD was dramatically different. The one in red is the DKD, which has gone down much more as compared to the NDKD population. Now, if you're looking at what are the histopathological parameters that we looked at, this is already mentioned. I told you this is how you classify the, and we tried to figure out now, is there something in the baseline data which will tell me that this patient of DKD is going to do worse than the other patient with diabetic kidney disease? And we looked at certain parameters, and what actually stood out was if you have interstitial fibrosis, if you have RPS classification 3 and 4, which is understandable, and if you have a very high degree of proteinuria at baseline, you are more likely to have a worse prognosis with diabetic kidney disease. So the 2 of them are histopathological and the others are clinical and biochemical parameters. So this we have gone and published recently looking at the composite renal outcomes. So to conclude, the renal outcome in DKD subjects is far better compared to NDKD is far better than compared to DKD. Higher degrees of glomerulopathy and baseline 24-hour protein excretions are predictors of renal events in DKD subjects. So my final take home, number 1, non-diabetic kidney disease is very common. It's not 5% as we learnt in med school. The criteria for biopsy is flawed, and even if you have a great criteria for biopsy, can you do a biopsy every year? Because for all of your complications you are taught, neuropathy screening once a year, retinopathy screening once a year, nephropathy screening at least once a year. So biopsy is not the answer in all our patients. NDKD has a far better renal prognosis if treated adequately and properly. Depending on the cause of non-diabetic kidney disease, specific treatment can be instituted. Threshold for biopsy has to be lowered, because right now, how many biopsies are we performing in patients with diabetic kidney disease? But there are challenges of biopsies. We need better ways of identifying individuals suitable for a biopsy, and that is where we need to find non-invasive biomarkers to tell us that these patients should be undergoing biopsies and these patients do not need biopsies. So that's where our studies are going on in terms of multiomics. We are doing metabolomics, transcriptomics, proteomics, and exosome studies. And I am grateful to all of my collaborators, my funding agencies, and all of the collaborating institutes. Hopefully in the next 5 to 7 years, we'll be coming up with better answers and less questions. Thank you very much.
Give an active applause, please.